Por favor, embajadora, gracias.
Buenos días, Dobry Den. Quiero darles la bienvenida al ciclo de capacitación internacional organizado por la Escuela Nacional de Salud Pública del Perú, INSAP, que en esta oportunidad presenta la conferencia virtual a cargo del Programa Humanitario Checo, MEDEVAC, adscrito a su Ministerio de Relaciones del Interior. En principio, quiero agradecer la receptividad del gobierno checo para intercambiar experiencias en esta crisis sanitaria que afronta el mundo desde el año 2020, debido a la pandemia del COVID-19 tan desconocida en sus fatales consecuencias, muchas de ellas letales. La República Checa es conocida por sus destacados científicos y sus altos estudios epidemiológicos. Y este intercambio de información, estoy segura, va a contribuir a la mejora del desempeño sanitario del Perú para seguir combatiendo esta pandemia con éxito. Aprovecho la ocasión para destacar que la relación bilateral entre el Perú y la República Checa se encuentra en un muy alto nivel de entendimiento, diálogo y cooperación en beneficio de nuestros pueblos, y que próximamente celebraremos los 100 años del establecimiento de las relaciones diplomáticas ininterrumpidas en el año 2022, que fueron iniciadas en 1922, cuando la República Checa formaba parte de Checoslovaquia. Este óptimo nivel de entendimiento ha propiciado una tradición de cooperación en preocupaciones comunes como la lucha contra el narcotráfico, la gestión de desastres naturales, la conservación del medio ambiente y mitigación del cambio climático. Asimismo, hay un alto nivel de intercambio estudiantil y académico entre las universidades de ambos países. Por ello, no debe de extrañarnos que los sólidos lazos de amistad entre ambos países nos motiven a afrontar conjuntamente los desafíos de esta crisis sanitaria global. Como todos conocemos, la pandemia causada por el COVID-19 afecta a todos los países del mundo, sin distinción, generando enormes obstáculos y desafíos a la comunidad global. Sin embargo, nuestra voluntad compartida de promover nuestras relaciones bilaterales de beneficio mutuo hoy se ve reflejada en el papel fundamental de nuestros gobiernos para continuar promoviendo el pleno bienestar de nuestras naciones. Quiero dar un especial valor al intercambio de ideas que se realizará hoy día, basadas en el conocimiento científico, la innovación tecnológica, cualidades que, como he resaltado ya, destacan en la medicina checa. En ese sentido, nuevamente los invito a escuchar y sobre todo a analizar los relatos que estos profesionales de primer nivel vienen a compartir con ustedes, los cuales no solo se basan en conceptos teóricos, sino, como vamos a escuchar, en un testimonio vivo de un colega checo que viene combatiendo el mismo mal que aqueja a nuestro país desde otra realidad. Muchas gracias a todos.
Muchas gracias, embajadora. A continuación, las palabras de la representante de la Escuela Nacional de Salud Pública del Ministerio de Salud del Perú, doctora Eliana Incio, directora académica.
¿Qué tal? Muy buenos días a todos. Reciban el saludo de todos los integrantes la Escuela Nacional de Salud Pública, en particular de nuestro director general, el doctor José Luis Seminario Carrasco. Realmente para la escuela es un honor y de reconocimiento muy grande para los trabajos de cooperación que viene haciendo en particular, y en este caso la República Checa, ¿no? La embajadora del Perú en la República Checa. Un agradecimiento para usted, embajadora Liliana de Olarte. De igual manera, un reconocimiento para los trabajos que desde el año pasado venimos impulsando de manera conjunta con la Dirección de Cooperación Internacional de la Dirección General para Asuntos Económicos del Ministerio de Relaciones Exteriores. Gracias a ellos, la escuela puede tener la oportunidad de acercar a ustedes este intercambio de ideas, de experiencias, sobre todo en este contexto que nos plantea la pandemia. Igualmente un reconocimiento y un agradecimiento especial para el Departamento de Infecciones de Buloca del Hospital Universitario de Buloca, a los conferencistas que hoy nos están acompañando. Nuestro agradecimiento, segura estoy, para todos los participantes, que ya veo que un número importante han acudido a esta invitación que ha cruzado la Escuela Nacional de Salud Pública. Segura estoy que va a ser muy valiosa la experiencia, como bien lo ha señalado la embajadora Liliana Olarte, de otros países, con seguridad contribuyen a esa otra mirada que podemos tener solamente para explicarnos, para retomar situaciones o simple y llanamente para esa retroalimentación que en un contexto como este se hace sumamente necesario. Desde la escuela les auguro éxito en estas conferencias y los invito a que estén atentos a que a las convocatorias que sigamos haciendo, perdón, para invitarlos a todo este ciclo de conferencias internacionales. Un gran abrazo para todos. Gracias.
Muchas gracias, doctora Incio, por sus palabras de apertura para esta conferencia de bienvenida. A continuación tendremos las palabras de la representante del Programa Humanitario MEDEVAC del Ministerio del Interior de la República Checa, señora Ana Pavlakova, coordinadora.
Muchas gracias también por la calidad de bienvenida. También me gustaría darles la bienvenida a todas en la sesión de hoy que se concentra en la pandemia de COVID-19. Mi nombre es Ana Pavlakova y soy la coordinadora del programa MEDEVAC Checa, que es un programa médico humanitario del gobierno de la República Checa. El programa está activo desde 1993 y se centra principalmente en el despliegue de equipos médicos en el extranjero, organización de capacitaciones para médicos en el extranjero y también en la República Checa, y la evacuación de los pacientes del extranjero para un tratamiento en la República Checa, y también en apoyo financiero de proyectos médicos en el extranjero. Y hoy las presentaciones... ¿Sí? ¿Puedo continuar? Bueno, hoy las presentaciones se centrarán en la pandemia de COVID-19 de la experiencia checa, y la presentación estará a cargo de nuestros principales epidemiólogos e infectólogos, Dr. Trojanek, Dr. Grebenjuk del Hospital Universitario de Bulovka y Dr. Smejkal del Instituto de Medicina Clínica y Experimental. Y ahora permítame cambiar al inglés, si es posible. Okay, so I would like to again say very welcome to you all, and I think we could, if you're ready, we could start with the presentation. So the first presentation will be held by the Chief Epidemiologist of the Institute of Clinical Experimental Medicine, Dr. Smejkal. And it will start basically the introduction to the COVID and also the treatment in the hospital. So if you're okay with that, I would give the word to Dr. Smejkal.
Hello, everybody. Buenos dias. I am trying to switch the video on, but unsuccessfully because I'm blocked. Do you hear me at least?
Yes, we do.
But you don't see me, right?
Well, maybe in a bit.
Because
No.
as the organizer switched me off, so if you switched me on, maybe you can see me as well.
Oh, okay.
Por favor, si pueden permitir la cámara.
Yes, I'm trying, but
Yes, it's
you
working.
see me? Okay.
Now you can share the screen, otherwise I will do that.
So let me introduce myself. My name is Petr Smejkal. I work as an infectious disease doctor, as a clinician, and also as a hospital epidemiologist in a hospital called ICAM, which in English translate as Institute of Clinical and Experimental Medicine. But we do not experiment here on our patients. We mostly treat transplant patients, diabetic patients, and patients with cardiovascular diseases. These are three parts of this hospital. And I am in charge of regulations against COVID, and I'm in charge of contributing to the care of the infectious part of those patients. If they have COVID, I see them for COVID. If other patients have infectious problems, that's what I do. I'm also part of the government team, which is trying to, and I have to say, not very successfully lately, which is trying to conquer COVID and make life of our country easier, because we are basically from the early December in a big lockdown, not a complete lockdown, but in a substantial lockdown. So I can tell you something about the government efforts, the Czech government efforts to deal with the pandemic in the Czech Republic. So I'll try to put some slides on. Do you see something right now?
No.
No, okay.
Before you tried, it worked. You can do it again. That may be why you were switched off, because you were sharing your screen.
Maybe I'm very bad at the technique, but
Otherwise, I can share it if you don't like, but try it first. You try it first.
maybe that would help me, yes.
Okay.
This is not good. If you can put the epidemiology part and then the vaccination, that would help me, so that everybody can see it, because I don't know how to put it on the screen here. Thank you. So you can move to the next slide. It says December 2020. Okay, thank you. So here you can see in December, we can see Peru having a different color on the map than the Czech Republic. And that is because that in December 2020, we were in the whole
We cannot hear.
Hello? slide. Yeah.
Yes, you're there. You can
Okay.
continue.
So here you can see the Czech Republic being in dark purple and Peru having a lighter color. So the Europe, the wave, next one, please. Yes, thank you. This is how Europe looks right now. Basically, you see how big the second wave on a European scale is. Those are data from ECDC, which is the European Center for Disease Control, where every member of the European Union reports the data. See how big the wave is. So we are actually one of the worst countries in Europe as far as number of cases, and also unfortunately as far as the mortality and the ICU deaths. So our case fatality is currently 1.6%. In the spring, it was lower, and we think it's because the ICUs and the critical care units are being filled up. They're not full yet. And the other factor is that the staff is quite tired and also infected as well. So the ratio, for example, of a nurse to a patient is going down, and that's why the care of the patients on a country level is decreasing. Next slide, please. This is the whole situation in Europe based on the ECDC data from the beginning of the year. So you see our country, the Czech Republic, being right in the middle, being dark purple, as is Spain, as is Slovenia, as is Ireland, which are currently kind of the black sheep of Europe. But the situation overall in Europe is pretty bad. There is no country that is spared. If we can talk about good situation, maybe we can say in Norway, which closed its borders to Sweden, and Iceland, which is an island, is good. And from the continental countries, a relatively good situation is in Greece. But otherwise, all countries are affected to a big extent. And we have not seen yet the effect of vaccination because I will talk to it later, but the import of vaccines to the whole European Union is slower than it was predicted. That's why countries like Israel and in the whole on the European continent, even Serbia, which is outside the European Union, are a little further as far as vaccination rate. So that is kind of hampering our efforts. The lockdown we have from December is not functioning very well. Thank you. This is the situation as far as testing. See, we do kind of on a European level decent number of tests, less than Austria, but at the moment probably more than in Germany, but we have way more cases. So these are mostly clinical and not epidemiological testing, but it's probably still not enough to know about all the cases that are in the country. This is the testing rate per 100,000 population. Also the data is from ECDC. So why am I showing it? It shows you that we have pretty much, we know pretty much quite well what the situation is based on the number of tests, or we can estimate pretty good that we are hit hard by the virus and the flow of the virus in the society is pretty big. We do a lot of antigen tests that added to the PCRs because we were doing only PCR up until, I mean, for the whole population up until December, and now everybody can also go for an antigen test. So that increased the number of tests in the country, and we know quite well where the virus is, and we know it's not good if you look at the map. Like I said, it's not the number of tests, the number of cases. What is concerning for us is the number of hospitals filled with COVID patients. And there are not as much in Prague, like the hospital where I work in has pretty decent situation, but If we go to the countryside, we always have to say that Prague has much better situation than the hospitals in the Czech Republic that are in the east of the country and in the very west of the country. We can speculate now only, but we can the British mutation of all the virus could be already the British mutation, which is, as you know, way more, or not way more, but it's more infectious by a reproduction number of 0.4 to 0.5. So the infection is now spread. The new mutation also has a higher fatality rate, which we'll see soon, but already, as I said, even the number of death patients in the ICUs is exceeding the level that Western European countries should be. We also face a lot of people who still, there are less and less, I have to say, but who still kind of don't put too much stress on this disease. So we always show them the excess mortality, which works very well to see how much we are above average of deaths. So this is mortality, this is overall mortality for the last 10 years in England, Spain, Jakarta, Indonesia, and Istanbul. And now please, the next slide, I put in the Czech Republic. Thank you. These are the years in the last 10 years, what the mortality was in the country, and this is 2020. So we can now say we have 16,000 more dead people last year. We had 16,000 more dead people in the last year than the previous years, which is for a population of 10 million, the worst situation we had since 1945, which was the end of Second World War. This clearly still raises this raises the most concern for us, and also raises a lot of doubts about some people, whether this is death with COVID or by COVID or on COVID. I don't think it matters at all, because we wouldn't have 16,000 dead people last year if we didn't have COVID, and that's where the debate should end. And but it's still going on here. Probably you know in Peru as well, that there's the people questioning whether it's COVID killing the people or their comorbidities. I think this graph shows it very well. Next paragraph, next slide, please. This is the COVID deaths seems to be climbing into 2021. That the Czech Republic the Czech Republic here is going up as well, very rapidly. So we'll probably have one of the highest in Europe as well. The funny part, or not that funny part of the Czech Republic, is that we were actually the best in COVID, so to speak, to use the words of our Prime Minister in the spring. We did have a big lockdown and we had very little cases and very little patients. And now we are one of the worst European countries as far as the COVID situation is concerned. Next, please. This is the hammer and dance, which we all know what to do. So I tell you what we do now. We certainly isolate every case. We trace. We try to trace every case, but a lot of the people just saying that they had one contact. So the numbers are not good as far as people giving the number of contacts. We basically closed schools. We closed all non-essential businesses and shops. Only if you want to buy food, it's possible. The Czechs love to go to ski. All the ski resorts are closed, which also raises a lot of protests in the country. And basically, we're in a situation when, unfortunately, a lot of the Czechs are starting to question all these measures and saying we're not willing to accept continue to live in this lockdown anymore, which is quite dangerous. The reason is the government didn't explain very well what's going on, and it's just taking too long. We call it pandemic fatigue. Pandemic fatigue. Next one. So as we go, the ministry says we have to take care of our healthcare system capacity. So that's why we do the lockdown. These are the curves showing how you kind of slow down the flow of the pandemic so that we not overwhelm the healthcare capacity. To that, I can tell you that the Czech Republic has quite a robust healthcare system as far as the number of hospitals and beds, because they were never a problem. But we have and ventilators and machines. That is all good, but we are lacking staff. A lot of our nurses in the last couple of years left for Germany and Austria and richer countries. So we have shortage as far as personnel. That is the bottleneck of our system. We are still able to take care of all our patients, but there are some hospitals, they have to transfer their patients to other hospitals throughout the country because they were just overflown. They had too many. And maybe we will be close to a situation where we'll also have to send some patients to other countries of European Union because they offered some assistance and help. Next slide, please. So testing, like I said, we do in the country, we do in the hospital where I work, we test every patient that comes to the hospital. We do both antigen and PCR tests. We do antigen tests for everybody so that we know everybody who comes here for a day, so that we know at least some information, and then we add the PCR, the result of which we have 5 hours later if the patient stays longer. So we screen everybody. We don't test our workers. We do test doctors at the transplant unit because we know that the mortality of transplant patients is about 8 times higher than every other patients. So we take care of, we do test on a regular basis, even the staff of the transplant centers. The other centers such as diabetes and cardiovascular, we don't do that because we would just run out of tests. Tracing, like I said, in the country, that's not doing very well, because a lot of the Czechs, when they have a contact with somebody sick, when they asked by the epidemiologist to give the context, they say they had 1 contact, and we all know they must have way more. So there is a little effort for people to kind of look at a pandemic as a solidarity common issue, and they don't want to, they do the opposite. They don't want to say, I met this guy, I met that person, because they're afraid that they would be angry at him, they would lose their jobs. So all the things that slowing down the efforts to fight the epidemic. And like I said, the measures in the country are kind of accepted by, are not accepted by some people, and they just don't obey them, don't go by them. Next one, please. This is what we go by in the country. It's a system based on points. This is, you get certain number of points based on the situation of how many infected people we have, how many infected seniors we have, how filled the hospitals are, and how many new COVID positive cases we diagnose, and what's the reproduction number. And out of that, we calculate a number, and then the country moves from one part to another one. And this says if the schools can be open, if sport can be done, and all the other things. It's not very functional lately because of the new mutations. We are actually kind of moving out of the system. Next paragraph. Next slide. Thank you. So this was kind of a preview on the country level. I have to also add, I'll talk about it later, that we started vaccinating. We have about 300,000 people vaccinated, which is 3% of the population. less than many other countries. We do have currently Pfizer, BioNTech, and Moderna vaccines, and yesterday we received AstraZeneca, but they're not the numbers we need to vaccinate a lot of the people in the country. So we are basically still in the lockdown that started in December. We have new mutation. We don't have a lot of vaccines, and we are not very happy about it, and nobody is very happy about it. But this will certainly go on until the spring. And now, before I move and I give word to my colleagues, something about what we do in the hospitals as well. So I talked about the testing of the patients. We do test also outside the hospital. We have a tent so that we don't let anybody come in. We use Panbio antigen tests, which are good to kind of pick up the infectious people. We always say they don't pick up the infection, they pick up the infectious and not the infected people, not all of the infected people, which we know, but they help us a lot in kind of screening and picking. Transplant center, because a lot of the transplant patients, we need to know specifically, even if they have a small number of virus. However, the recent study, and you probably have read it as well, there was a good study, there was a good paper in New England Medical Journal, shows that basically all those cycles above 30, the cycle threshold is 30, is a dead. But it helps us a lot, the cycles, to say, you know, somebody cycle 34, we don't need to do any measures because it's not an infectious patient, it's a dead virus. And there is somebody whose cycle is 20, we know that he's highly infectious. So I don't know if in Peru you do that as well, but the viral load analysis and the cycle threshold help us a lot in differentiation. On the hospital level, we don't do sequencing. We're gonna buy some primers for PCR, so we'll know about the mutations just by doing simple PCR. But there are centers in the country that started to do sequencing, so we will know more about what variations of the virus and mutations are in the country. And as far as outbreaks, next slide, please. Next slide. This is the country number of COVID positive personnel. It's from last year. If we continue this into this year, it's sharply going down, which is basically, I think, the 1 out of 2 probably positive news in the last month, that we achieved more than 50% vaccination of healthcare personnel. So the number of infected healthcare workers is going down. And we could see that on the hospital, that we had 100 positives employees, and now we have 18 within a matter of 3 weeks after they received the first and second dose of Pfizer. So the problem of infected healthcare workers or exposed healthcare workers or quarantined healthcare workers, we hope is a history, because the first vaccines went to healthcare workers, and they are most of them are already vaccinated in our hospital. The second big dose went to elderly people, but I'll talk about it later. So the outbreaks in the hospital are, I hope, going to be history as well. Next paragraph. We still do, however, wear respirators. We still do not do rounds when we see patients, only in a couple of people. We still, next paragraph, please. This was just to show we use FFP2 for healthcare workers, and we use FFP3 for any aerosolized procedures, any bronchoscopies, intubations, and contact with highly risky people with high viral load. We use FFP3. Next one. We, of course, banned masks. We use only respirators already for a long time, but with the arrival of the new mutations, it's even more important at this moment to stress on respirators and not just masking. And of course, the vaccine is the solution, but when we're going to be all vaccinated is a question. Next one. We have a major outbreak in the ICU, one from a patient that was transferred to us from another hospital, was tested in the other hospital as negative, and we didn't do the test on arrival here, and she was positive. We didn't know. She was a cardiac patient, so she was coughing, and all the cardiologists thought it's a cough from, it's a cardiac origin cough and shortness of breath, and she had COVID pneumonia, which was discovered 5 days later, and in the meantime, she infected almost all the staff in the ICU. So, which is not as perfect, which is separated just by sections, of course. So the transmission was far. Fortunately, only one patient, there was several patients got infected, only one patient died. It was a post-transplant patient, and it was our one and only victim of COVID as far as the transplant patients we know about. Others might be in the country, but we still talk about it because there was several things that didn't go well. Like we reinstituted proper testing for every patient to our hospital. We do our own tests. We basically don't believe in any other hospital testing. And we test some of the transplant patients on a regular basis, every 5 to 7 days when they're here for a long time. Next slide, please. The nosocomial spread, if this was from a patient, but the biggest nosocomial spreads we had among staff was from cafeteria and eating in cafeteria. It was very interesting. Our tracing showed us that the Czech doctors and maybe doctors all over the world, when they faced some patient, they're properly dressed, while when they take the sitting, drinking, everybody eats on its own in his own little corner, and like I said, now with the vaccinations, these problems are basically gone. And this would be it for my first part as far as this, and I'll then get back later to you with vaccines and vaccinations, and I hand it over to my colleague. Thank you.
So good morning to all of you. I'm very glad that there are so many people listening to us, and I really appreciate that. And I hope that our part, which is from the University Hospital of Bulovka, will be useful to you. We tried our best, especially my colleague, Dr. Grebeňuk. He prepared for you an evidence-based lecture focused on treatment and diagnostics, especially in terms of the positive and negative predictive values of rapid antigen tests, which is a huge issue, and I think that it might be useful for you. And similarly, he is going to cover all that evidence we have in terms of treatment, because as we know, there were a lot of issues in our country, for example, with some immunomodulatory drugs, or for example, with hydroxychloroquine. And we know that the similar issue is in your side, which is concerning ivermectin. So actually, that would be our contribution. And then, because I'm really interested in antibiotics and well, their rational use, I'll try to cover at least a little bit a topic of rational antibiotic use and prescription, and the topic of secondary bacterial infections in COVID-19. So I really do appreciate that there are so many of you who are listening to our lecture. I hope that we could have also some kind of interaction. So if you are interested in what we did, what we are doing here, we would be very grateful. And unfortunately, I have to say this, we are doing the presentation because we did a lot of mistakes in our country. I think that we did a lot of things not in a good idea or as the best. And that's why we would be very grateful if you just could take, if we could just share our mistakes with you and you just do not do them as we did. So that's our main intention. So I think that I can pass the words to Dr. Grebeňuk. He is our clinician and PhD student, and his major interest nowadays is not tropical medicine as it used to be, but it's mainly COVID-19, and he is very active, especially in education of Czech doctors regarding the treatment regimens, and so on. So the floor is yours. Slavo, it's yours.
Okay, thank you very much. Can you hear me?
Yes, we
Yes,
can.
we do.
Okay. And can you see my slides?
Not
No.
yet.
What about now?
Nope.
Okay. How about now?
Yes.
Okay.
Now it's working. Great.
Okay, I would like to share with you the Czech experience of treating COVID-19 infection, and mostly I will talk about the mistakes we have made over and over again since the beginning of the pandemic. The pathogenesis of COVID-19 disease is often thought of as having several stages. In the beginning of the disease, there is an active viral replication going on in the respiratory tract of a sick person, which is correlated with peak viral loads in upper respiratory tracts and also mild respiratory symptoms. And then in a smaller percent of individuals, the disease proceeds to affect the lungs, and this is correlated with symptoms of shortness of breath and with clinical findings of hypoxemia. And from this point on, most severe complications of COVID-19 are more a matter of host inflammatory response to the virus, not the viral replication itself. So in the early stages of the disease, you really want to give some drugs that directly target the virus itself and limit its replication. That would be your classical antivirals like remdesivir or interferons or lopinavir, ritonavir, or others, and other agents that would block the virus itself, like monoclonal antibodies, for example. In the second stage, where the hyperinflammatory immune response of the host is the main issue, you would need to give drugs that will be able to block or mitigate this hyperinflammatory immune response. So this would be your classic immunosuppressants like corticosteroids, IL-6 inhibitors, and others. And it is interesting that we had the most success exactly with those kinds of treatments that are immunosuppressive. And by definition, those treatments are very not specific. They do not act only against the virus itself. They target only the host inflammatory response. And these drugs can be given only to patients with severe or critical diseases. So they won't help every patient with COVID-19. What is really lacking at this point is a drug that is easy to use, that is oral, and that is safe, and that can be given to patients with mild disease to prevent them from getting severe complications altogether. And maybe this will be the area of future research. So there have been a lot of guidelines have been developed since the beginning of the pandemic. Most of them are in the form of living guidelines, which means that they are getting constantly updated as far as new evidence comes out or is being evaluated. And this is from WHO living guidelines for treatment of COVID-19 infection. And I like it very much because it's very simple and very clear. The only recommended medication for the treatment of COVID-19 is corticosteroids, and you only need to give them to patients with severe or critical disease, to those patients who require oxygen support. What is also notable in these guidelines is that there is also weak recommendation against the routine use of remdesivir, and not all guidelines share this point of view, but this just goes to show you that the data on the treatment of COVID-19 is really ambiguous, and we really don't have any clear-cut proofs that any medication work at all. So in Czech Republic, we originally started treating COVID-19 with hydroxychloroquine, which is an antimalarial drug, which is now mostly used for treatment of systemic lupus and other rheumatological conditions. And it has been shown that it has some activity against the variety of viruses in vitro on cell cultures. And also there was, we started treating people with hydroxychloroquine because we had this very small single-arm trial that has shown some benefit in using hydroxychloroquine in patients with COVID-19. This trial has several severe methodological limitations because it included only 20 patients, and also 6 patients from the treatment group, from the group that received the hydroxychloroquine, had dropped out from the trial because of ICU transfer. There was 1 case of death and 1 case of discontinuation of medication because of severe adverse effects. So it wasn't just routine loss to follow-up patients. It was really the studies offered no proof that this adverse effect were not caused by adverse effects of hydroxychloroquine. And yet we started using hydroxychloroquine anyway because we had no other, because we just wanted to help our patients in any way that we could. And we just treated patients with this hydroxychloroquine. And during the spring of 2020, there were several studies. 2 of them were retrospective cohort trials studies, and 2 were prospective trials that showed no benefit of hydroxychloroquine. And really the culmination was a study released by Lancet, which was a retrospective cohort study, which included 96,000 patients with COVID-19 admitted to 671 hospitals around the world. And in this study, it was shown that hydroxychloroquine was not only associated with, not beneficial in patients with COVID-19, but was also associated with a significant risk of death and ventricular arrhythmias. And based on this result, WHO decided to halt the hydroxychloroquine arm of the Solidarity trial, and more than 100 other trials were terminated around the world. But what was really unexpected is that several weeks after this study was published, the Lancet retracted the study because several people just started to have concerns about the validity of the data set, and there were several inconsistencies in the data, and Lancet just asked the authors of the study to conduct an independent third-party analysis of the original data set. But the company Surgisphere, which originally provided the data, refused to give the original data set because they claimed that it would interfere with some privacy issues, and so this study was retracted. But before it was retracted, it affected international healthcare policy in many ways, and was the reason for the termination of several trials, including hydroxychloroquine. So after this study was retracted, the Solidarity trial proceeded, and eventually it showed no effect on mortality, ICU admissions, or hospital length of stay for hydroxychloroquine, and much the same results have been found for other medications that were investigated in this trial. This included remdesivir, lopinavir, interferons, and interferons. So no medication was proven to have any effect on hospital mortality or any patient-relevant outcomes, according to this trial. So there's really not much left to say about hydroxychloroquine at this point, besides that it clearly does not work. And also it has the potential to cause some severe adverse effects, including QT prolongation and ventricular arrhythmias. Then, after we stopped giving hydroxychloroquine to our COVID-19 patients, there came an era of remdesivir, and it continues, it goes on up to these days, although we do not give that, we do not give that much remdesivir anymore, but we still do give it. And most of the data that supports the use of remdesivir comes from this trial, which is called ACT-1 trial. It was a randomized, double-blind, placebo-controlled trial, which compared remdesivir versus placebo. And it was observed that the use of remdesivir was associated with a significant decrease in the time to clinical recovery. There was also a numerical trend toward lower mortality and in patients receiving remdesivir, but it was not statistically significant. What was statistically significant, however, was the reduced mortality in the specific subgroup of patients who were receiving, who had severe disease with hypoxemia and received low-flow oxygen therapy. There may be some benefit in patients who have severe disease and require oxygen support, but not those who are mechanically ventilated or receive high flow nasal oxygen or non-invasive ventilation. As I have mentioned before, the Solidarity trial have demonstrated no benefit of remdesivir regarding mortality, need of mechanical ventilation, or duration of hospital stay. In the accompanying meta-analysis that came along with Solidarity trial, there was some numerical trend toward lower mortality in patients who were not mechanically ventilated at baseline among the patients who received remdesivir. But once again, this was not statistically significant. So the results, of the trials regarding remdesivir are really ambiguous, and there's really no clear-cut proof that it works. Favipiravir is another drug that we used for a while in the late spring of 2020 to treat COVID-19 patients. It is a classical antiviral drug. It is an RNA polymerase inhibitor developed and used in Japan to treat influenza. And there were some early data from Russia and China that was mostly observational data from small trials, small studies that suggested that favipiravir may have some clinical benefit. And for example, this small trial from India in 150 patients with mild to moderate disease have shown a little bit faster recovery and faster cessation of viral shedding in patients receiving favipiravir as opposed to those who receives the standard of care. What is notable in the study is that they also include asymptomatic patients. So it's really the validity of these results, especially regarding clinical recovery, is very low. Thus far, there have been no data to assess any of the clinically relevant outcomes like mortality or progression to severe disease or the need of mechanical ventilation. So ivermectin is an parasitic drug that is used for treatment of several helminthic infections. And this drug, it has long been known that it has some in vitro activity against a wide variety of DNA and RNA viruses, and SARS-CoV-2 just happened to be one of them. The proposed mechanism of action of this agent on those viruses is by inhibiting the important mediated transport of viral proteins in and out of cellular nucleus. So with ivermectin, there has been a similar story as with hydroxychloroquine. In April 2020, there was, this study was not published, but was released as a preprint. But it was also based on the data provided by Surgisphere, and it suggested that ivermectin significantly reduced mortality in patients with COVID-19. This study has claimed to be was a retrospective study and was comparing patients who received ivermectin with patients who received standard of care or other drugs. And it was claiming to be the data that was used was claimed to be acquired from several hundred of hospitals all around the world. And based on this preprint, several Latin American governments and health organizations have changed their guidelines for clinical care of COVID-19 infection, and they included ivermectin as a recommended medication for COVID-19 treatment, which was later denounced by Pan American Health Organization. And as is, I have a quote from the Guardian here in an article that was dedicated to Surgisphere and the flow data that they provided for this for several trials for COVID-19 medications. They actually compared like ivermectin to hydroxychloroquine, meaning that ivermectin has had this, there's like very similar stories, ivermectin and hydroxychloroquine. So besides this flow data from this retracted trial, what we have for ivermectin, there have been some low quality observational data that suggested some benefit for ivermectin, but the trials were really small and the validity is really questionable because also other medications were used. Later there has been released an analysis and a review of pharmacokinetic data of ivermectin plasma concentrations, which was acquired from patients with parasitic infestations and also from healthy volunteers. And based on this analysis, it seems very unlikely that ivermectin is able to achieve significantly high plasma concentrations that would be able to inactivate the virus in vitro. So all this sheds a lot of doubt on the whole idea that ivermectin might work in any significant way. Later, there were some trials. All of them were really small and none included more than 75 patients. And all three of them have shown no benefit of ivermectin compared to standard of care. Also, there are some more unpublished and not peer-reviewed trials. For example, this trial from Iran is a double-blind, placebo-controlled trial that compared various dose regimens of ivermectin with either standard of care or standard of care plus placebo. And it has shown that ivermectin was associated with more than 80% mortality reduction, which of course sounds wonderful, almost too wonderful, but there have been no proof. Like there are some serious methodological limitations to this study, including small size, other medications that were used in patients who received ivermectin, and also standard of care, and also the severity of the definition of severity of COVID-19 was not very well specified in this trial. This second trial is from Argentina, is smaller and shows no difference in viral load reduction when using ivermectin versus standard of care. So to sum up, we may say that for ivermectin, we have only low quality and mostly unpublished data. And on top of that, most results do not favor the use of ivermectin over standard of care or placebo. And also, ivermectin is not recommended outside of randomized controlled trials with appropriate ethical improvement. This is explicitly stated in several guidelines, including IDSA guidelines, the National Institute of Health guidelines, and Australian guidelines. The WHO guidelines do not even mention ivermectin at all. So there have been two major trials on monoclonal antibodies in treatment of COVID-19. Both of them were in outpatients and non-hospitalized patients with mild to moderate disease. And both of them had very similar results. They observed more viral load reduction in patients who received monoclonal antibodies. And there were also fewer medical visits or hospitalization related to COVID-19 in patients who received monoclonal antibodies. What is important is that in the most effect was observed in patients who had not yet mounted their own endogenous immune response to the virus, which means the patients who still did not have their own antibodies against the virus had the most significant results. The effect was minimal in those who already had some antibody production going on. Still, there is limited data on other clinically relevant outcomes like progression to severe disease or death. And given monoclonal antibodies to people may represent some serious logistic issues, because to give monoclonal antibodies, you need to give it intravenously, which is associated with several infusion-related side effects like fever, chills, and abdominal pain or skin rashes. So the people who receive monoclonal antibodies need to be observed during the time that they receive this drug, and also for several minutes after. And this would, of course, place some additional requirements of medical facilities and medical staff that is already overwhelmed by caring for people with severe disease, with severe COVID-19. But if we do want to use monoclonal antibodies, we should preferentially use them in non-hospitalized patients with mild disease, and we should give them as early as possible, because otherwise it doesn't provide any benefit if you give them to people who already have their own antibody production going on. And also, we should preferentially give them to patients with risk factors for development of severe disease, like obese patients, patients in old age, and patients with chronic comorbidities. Convalescent plasma works on the same principle as monoclonal antibodies. The only difference being that instead of giving a patient an artificially manufactured neutralizing monoclonal antibodies against SARS-CoV-2, you give them plasma of people who actually had COVID-19 and have recovered. And such plasma may or may not contain the sufficient amount of neutralizing antibodies against SARS-CoV-2 S protein. Unfortunately, in Czech Republic, we do give convalescent plasma a lot, maybe even more than would be suggested by guidelines. And we mostly give it to hospitalized patients, and we give it pretty late. Unfortunately, this Cochrane Library Living Systematic Review that analyzed multiple randomized controlled trials it concluded that plasma has no clear benefit in terms of reducing mortality or severe complications of COVID-19. In this randomized controlled trials, however, there was one limitation. In most of these trials, the patients received plasma relatively late. The median time from onset of symptoms was between 8 and 30 days. And also there was the titer of neutralizing antibodies and in plasmas that were used was variable. So this may be one of the reasons why plasma didn't work. Different result was seen in this randomized control trial, which used only high titer convalescent plasma, and they gave it to patients really early, which in this trial meant that they gave plasma to patients who had who were less than 72 hours from the beginning of their symptoms. And in this trial, given convalescent plasma was associated with a significant reduction of severe complications. The relative risk reduction of severe disease was about 48%. Most of the evidence on corticosteroids comes from this trial, which was a randomized open-label trial from United Kingdom comparing dexamethasone to standard of care. And in this trial, the investigators have observed that given oral or intravenous dexamethasone was associated with 17% relative reduction in 28-day mortality in the overall population and the 36% reduction in patients with critical disease. So in patients who were on mechanical ventilations or ECMO. Conversely, no benefit, and actually there was a trend toward higher mortality was observed in patients who were not, who did not require oxygen support at baseline. So besides dexamethasone, we do not have much evidence on other corticosteroids. This meta-analysis has also shown significant reduction in mortalities with the use of any corticosteroids in patients with severe disease. But the most effect was observed with dexamethasone, which reduced mortalities almost by 40%. Other corticosteroids like hydrocortisone or methylprednisolone had smaller effect, but also there were much less patients who received either hydrocortisone or methylprednisolone than those who received dexamethasone. So maybe in larger studies the effect would be the same. This is from another living systematic review and meta-analysis by British Medical Journal, and according to this meta-analysis, corticosteroids are actually the only medication that that is associated with where we have at least modest evidence that it may reduce mortality in COVID-19 patients. What is notable is that for remdesivir, there was found no statistically significant association with mortality reduction. Interleukin-6 pathway inhibitors include tocilizumab, sarilumab, and cetuximab. These are monoclonal antibodies either against the receptor of IL-6 or the IL-6 itself. And the results in published trials were generally mixed, and most trials have failed to show any significant reduction in mortality or severe disease in patients who received this biologics. However, there is also one trial called REMAP-CAP, which is a randomized controlled trial, which includes only patients with critical disease, so only patients on ICU, and they give those patients two different IL-6 inhibitors, tocilizumab or sarilumab, really within 24 hours after ICU admission. And according to the preliminary report from this trial, this was associated with a significant reduction in hospital mortality, and also with the reduction of days of organ support. So it is possible that IL-6 inhibitors may be beneficial in COVID-19 patients, but only in select group of patients, which are patients that have critical disease and are admitted to ICU. There has been much discussion about vitamin D among medical researchers, but especially in the media. However, the amount of available evidence remains scarce. There has been this small open-label randomized trial from Spain that showed some reduction in ICU admission in patients who received vitamin D for COVID-19 infection. However, this trial, apart from being small, also there were several confounders, like patients were also receiving alternative medications for COVID-19, like hydroxychloroquine or azithromycin. There is also this unpublished double-blind randomized trial, which is a bit bigger, with 240 patients, and it showed no difference in mortality or ICU admissions between patients who received vitamin D or placebo. Also, there was no difference in the length of hospital stay. However, while we do not have enough evidence that vitamin D may help treating COVID-19, we do know that vitamin D may help prevent you from getting the infection, based on the results of this meta-analysis that was released recently in January of 2021. And this is not something specific to COVID-19 alone. Similar evidence exists for other respiratory infections and also for community-acquired pneumonias. I don't know about Peru, but in Europe, vast majority of population is deficient in vitamin D, and maybe given vitamin D to people at risk of getting COVID-19 may help prevent the disease to some extent. So, as a conclusion, I would like to reiterate that as of yet, we still do not have any safe and efficient treatment for COVID-19 that would reliably work in all patients. And we have learned a lot from our mistakes, which was mostly over-interpreting the low-quality data, which can have massive impact on health policy and clinical research. And we also know that because of the medications that are available for the treatment of COVID-19 are very unspecific, they do not work equally well for all patients, and different patients may benefit from different interventions. Therefore, one size does not fit all. And according to most guidelines, not a single medication is recommended outside of randomized controlled trials with appropriate ethical approval besides corticosteroids, and possibly, according to some guidelines, also remdesivir in select groups of patients. Okay, thank you very much. This would be all as regards treatment of COVID-19, and I also have some
So thank you very much. I'm very glad that we could hear this presentation by my colleague and by my PhD student, by Dr. Grebenyuk. I think that at this time, we could include a part which is going to mention the rational use of antibiotics in COVID-19. And then if Petra is okay, we could do a discussion and his presentation about vaccination strategy in the Czech Republic. And if we have some time at the end of the seminar, we could include our evidence-based lecture on diagnostics of COVID-19 and the pitfalls in the diagnostics. So if it's okay with Peter, I would continue with antibiotics, and then we will share the screen and continue with vaccination. And if there are any reasons for that, or if there is your wish for that, we could include at the end of the seminar the diagnostics. So Slavo, thank you very much. I'm very glad that we could hear the presentation, and now I'll try to share the screen with my presentation. So thank you very much. So I hope that all of you can see my slides. If so, please nod your head.
Ano, děkujeme.
Thanks a lot. So actually, I'm very interested, especially in antibiotic use in hospital settings and in outpatient settings. Now, I work as the head of the Department of Infectious Diseases, which is intended for the education of Czech doctors in primary care, especially in primary care. So I'll try to cover this topic. And your previous topic was antibiotic prophylaxis in COVID-19. I'll try to sum up our evidence, what we have, and we will then continue with the guidelines, and I'll present a nice guidelines, which are the UK guidelines, one of the best in the world we know, and which are very useful for your clinical practice. So first of all, I just would like to mention that there is a huge problem with the potential end of antibiotic era. What we all know is that the major antibiotic classes were introduced, well, some 10, 20, 30, 50 years ago. And unfortunately, there's the lack of new antibiotics. I think that there have been, or there were a few projects which were funded by the EU and the United States, and they did some support for the pharma companies, and they tried to invest into the development of new antibiotics. But the problem is that they are all, well, the majority of them is just the modification of the old antibiotics, and sometimes the antibiotic resistance is shared and is common to those new and old antibiotics. So that's why we have a real problem that there's the lack of a new or totally new antibiotics. And that's why we have to appreciate that we have only those antibiotics left, and we have to work with them very wisely, very carefully, and we have to use them in a rational manner. So what we know, and what is a huge problem, and there have been many campaigns by the WHO, CDC, ECDC, we know that the risk of antibiotic resistance is growing all around the world, in developed countries, in the developing countries, and if we do not act right now, if we do not stop overusing antibiotics, there will be more deaths due to resistant infections than due to cancer, road traffic accidents, and so on in the world. So the antibiotic resistance and the impact of resistance all around the world would be really tremendous, and it will be a huge problem to all of us. So what we are doing, what we are trying to do, and we are not as good as the colleagues in the United States or in other developed countries, we are trying to persuade the clinicians, stop overusing antibiotics, try to think, well, whether it's really important, whether it's really necessary to start the antibiotic treatment. And as I mentioned, there will be approximately 50 million deaths due to antimicrobial resistant infections. And it means that if we don't do anything in 2050, there will be one death every 3 seconds due to antibiotic resistant infection, or due to infection which is caused by antibiotic resistance bacteria. And we know that from the clinical practice practice right now. We have at our ICU patients who are colonized, for example, by Acinetobacter baumannii, which is multi-resistant and almost it's impossible to treat the infection. We have a great problem with extended spectrum beta-lactamases or beta-lactamase producing bacteria, and that's an issue which is really concerning us a lot. And I think that the situation might be very similar also in other countries. So what we really need to think about is that antibiotics are different. I know that you are specialists, I know that you know that, but please just tell it to your colleagues who are not ID experts, who are not experts on microbiology. Just tell them that antibiotics are totally different from other drugs. And the major difference is that if you start treating the patient, for example, with antihypertensive or oral antidiabetic, you are just acting on the receptors of eukaryotic cells. And these receptors are stable, they do not change a lot, and they affect, or these drugs affect only your own eukaryotic cells. If you try to treat an infection like erysipelas, as you can see here, we as a doctors sometimes think that we are acting just on the bacteria which is there, which is overgrown in the site of the infection, but that's not true, and that's the major problem. Whenever you start antibiotic treatment, you are doing harm to your microbiome. It's a huge issue of concern all around the world. It's a huge issue in the United States, in Europe. We are getting new and new information which tell us that if you use antibiotics and if you just change the microbiota, you could do a lot of harm to your own body. And in addition, there's very good evidence for the fact that we are increasing the resistance in the community, because these bacteria are selected. We do a selection by the antibiotic choice, and then the antibiotic resistant strains can spread. I think that this slide is very clear. Just imagine that you start your antibiotic treatment. You have just a lot of bacteria there, which are usually susceptible to the antibiotic, but there are only few of the resistant bacteria. And if you start the antibiotic treatment for whatever infection, you are going to do harm to your intestinal microbiota, and there will be definitely a selection and overgrowth of the resistance bacteria, which then spread to other people. I know that you as ID doctors know that, but please do marketing and do some kind of action and just tell it to all your colleagues from the primary care, from surgery, from internal medicine departments or medical departments, and just try to persuade them that this is a huge problem and that we have to really use it carefully. When I was last time at the course at the Harvard Medical School in Boston, there were very good slides which just tell us that there are also other issues from antibiotic use. So all the time we are going to prescribe antibiotics, we have to think about pros and cons. And there are so many of risks with using antibiotics. It's not only about, but the major point and the major thing I'm going to present is the antibiotic resistance, but there are so many other problems with that. Antibiotics are a very potent allergens, so actually there is a huge number of allergic reactions to antibiotics. There are causes, or they are causing mycotic or secondary infections, secondary bacterial infections due to resistant bacteria. They could cause a C. diff infection, a huge problem, huge issue in our country, for example, and many other problems like a destruction of microbiota. By the way, the side effects, especially in terms of adverse events, adverse allergic events, is also of huge concern, because antibiotics and antibiotic use leads to a great number of consultations, emergency consultations due to side effects. And what was interesting to me, antibiotics are one of the most frequent causes of those emergency consultations. If we have a situation, a theoretical situation, that there's a patient with a viral infection, if there's a patient with infection that does not need an antibiotic treatment, and if we prescribe the antibiotics, we are doing the harm to the patient, because there's a much more likely situation that he will develop any side effects and any problems from the antibiotic itself, and we do not do any good to the patient. And that's really important to think about. There's a very interesting study which just tells us that if you give a patient ciprofloxacin or clindamycin, which are very unecological drugs, very unecological antibiotics, you do a long-term harm to the intestinal microbiota. And these problems last for, or the changes in the microbiota could last for more than 12 months. So for a very, very long period. And this is a very good meta-analysis which just tell us very clearly that the major source of antibiotic resistance is the antibiotic prescription in human medicine. So if you just compare those data, if you look at the data, they tell us what is the ratio of antibiotic, or what is the risk of isolation of antibiotic resistant strain after antibiotic use. And you could see that the risk is increased for more than 6 to 12 months. So antibiotic prescription is the major driver of antibiotic resistance, and we have to admit that, and we have to work with that. So that was my introduction, which was very important just to understand that antibiotics are extremely useful drugs, which are totally different from all other drugs. And we have to take that into account while we are prescribing them. So we have to have a very good reason for antibiotic treatment. And my question is, does COVID-19 possess a good reason for antibiotic treatment? And let's look what's the evidence. So first of all, COVID-19 is a very tricky infection. You all know it, that's an infection which could lead to a vast majority of complications. For example, we have seen a lot of patients with thrombosis, and well, it's not a pulmonary embolism, it's a pulmonary thrombosis, which led to the death of people who were not having ARDS or acute lung injury. They just had COVID-associated coagulopathy and died of pulmonary thrombosis. So that's one of the facts. And COVID-19 is a really very tricky infection, and it's different from what we have seen. First of all, we have to understand that it's a systemic viral infection which leads to overwhelmed immune response. That was presented on the first slide of Dr. Grebenyuk's presentation. And what is different from what we know, that it's a severe disease, it leads to severe complications, and it's just due to a viral infection. So the vast majority of complications are just due to virus itself. One problematic point is that in the majority of patients, even with uncomplicated COVID-19 infection, there's the increase in the inflammatory markers. I don't know what is the situation in your country, but in our country, every general practitioner, every primary care physician has a possibility to do a POCT, point of care testing of CRP. And the CRP is understood by our doctors as the major laboratory marker, which could help you to distinguish between viral and bacterial infection. So if it's low, it's a virus. If it's high, it's bacteria. And that's something what's not true in COVID-19. In COVID-19 infection, because it's an overwhelming immunopathological infection, it's a systemic viral and infection which leads to overwhelmed immune response. There's, in the vast majority of patients who are hospitalized, severe increase of CRP and of inflammatory markers. So in this case, you can't rely on CRP as the marker of bacterial infection. And that's very important to understand. That's a very important point to understand because we can't rely on that marker in distinguishing whether this patient needs antibiotics or not. I do understand the question. I do understand why we should think about antibiotic prophylaxis in COVID-19. I know that a lot of patients die due to COVID-19, and we are asking, could we do a little bit for them? Could we do a little bit good to them if we just give them antibiotics? And I also understand that the question is probably or was influenced by the influenza infection, because in influenza, we know that there is a very frequent secondary co-infection rate, or there is a very frequent rate of bacterial superinfections. And in this meta-analysis, it's almost 1/3 of all patients with influenza develop, or with severe or complicated influenza, develop bacterial infection. And these infections do have a devastating impact on patients. They are usually caused by gram-positive cocci, such as strep pneumo, strep pyogenes, or staph aureus. And that's why I would understand, or I could understand, why we should talk about it. But the question is whether this happens also in COVID-19. And what is the data? What is the evidence for that? And I have chosen this meta-analysis for you. It included more than 3,500 patients with COVID-19. It was a total of 24 studies, which had a good design. And the authors included either studies from hospitalized or critically ill patients. And what is the infection or secondary bacterial infection rate? It's extremely low. It's very low. If you look at this slide, the bacterial co-infection in hospitalized patient was proven in less than in 3% of patients. And the secondary bacterial infection was proven in less than 1/5 of the patients. So actually the co-infection or secondary infection rate is much lower than in case of influenza. Second, what is important is to stratify whether we talk about all patients or critically ill patients. And it's quite evident that these superinfections occur especially in critically ill patients. So in the patients who are on the ICU or HDU, but not in, for example, outpatients or in inpatients who are not requiring, for example, even oxygen and so on. So I think that it's quite sometimes very hard for us to understand, but all that damage, all that problems, all that inflammation, all that stuff is caused mainly due to virus. And there is a very low data for suggesting that, or there is a very good data for suggesting that there is any severe impact or high impact of bacteria in doing harm to our patients. So if we sum it up, and if we just think about the potential risks of antibiotic prescription and about a very low benefit to our patients, it's really hard for me, and I would not recommend just antibiotic prophylaxis in COVID-19 patients. I think that it would lead to a much more harm. It would lead to a harm in individuals and in the society as well, because it will lead to increase of resistance, and it could do a lot of problems. So the problem is, and also the authors of this systematic review, which was published in Clinical Microbiology Infection, they just say that there is a huge problem with overuse of antibiotics in COVID-19 patients. It's the problem not only in your country, it's definitely the problem all around the world. And to be honest, even for us as the infectologists or ID experts, it's very hard to persuade the clinicians from internal medicine ward not to give the antibiotic to a patient with COVID-19 lung infection, because they just say, okay, let's do a little bit for the patient. but that's not a good strategy. So one more thing I just would like to tell you is that there's also the difference from antibiotic or between antibiotics. There are antibiotics which are much more risky in changing the microbiota, which are much more risky in developing resistance. And there are some antibiotics which are a little bit better than the others. And we tried to persuade our primary care physicians just to tell this to all of them and to persuade them to use these, let's say, more ecological antibiotics. And interestingly, in 2019, the World Health Organization just developed a VAERE classification of antibiotics. It's a strategy called Adopt a VAERE, and they stratified the antibiotics to those ecological and to those non-ecological ones. So they stratified the antibiotics into 3 groups. Into group excess, those are antibiotics which are effective, but they have lower impact on the microbiota, lower impact on the development of resistance, which are just more ecological. And then are watch and reserve antibiotics, and you should not use these antibiotics. There's a stop for them, and you should try to avoid these antibiotics as much as possible because they are risky. They are risky for the development of resistance, and they are risky for the development or for changing the microbiota. And that's how the AWARE guidelines look like. We could just look at it, and there's just a suggestion for the best or for the optimal antibiotic regimen in different situations. There are also information about each individual antibiotics, and I just add here the table of antibiotics from the excess group. So these antibiotics should be preferred. These antibiotics are much more ecological than the other ones. So what we should prefer if we try to do a good antibiotic stewardship, we should definitely prefer a narrow spectrum penicillin antibiotics if it's possible. According to the antibiogram, we should definitely prefer doxycycline. We should prefer cotrimoxazole, potentially chloramphenicol. These are antibiotics which are much more safe in terms of ecology and of ecological impact on the development of resistance. These antibiotics are those which we should limit. And for your information, the most risky or very frequently used and risky antibiotics are fluoroquinolones. Even in the United States, which was the motherland of fluoroquinolones, there's a huge stop to these antibiotics due to their side effects, due to the risk of their use, and due to resistance. So fluoroquinolones are definitely on the blacklist, and we try to limit their use as much as possible. The same is true for third-generation cephalosporins, which are very good inducers of ESBLs, of extended spectrum beta-lactamases. So that's what we are trying to limit. And my last slide concerns NICE guidelines. You could very easily look it up on nice.org.uk, which is the website of National Institute for Health and Care Excellence, and they just offer a very precise and very good guidelines for almost all clinical situations, including antibiotic resistance. And one of the guidelines is when to prescribe antibiotics in COVID-19 patients, and they just share very similar issues as I told you. First of all, they just say that if you have a patient with COVID-19, it's not very reasonable to rely on CRP because there's a high increase of CRP even in patients with just a viral COVID-19 infection. So it can't distinguish the bacterial and the viral infection. So they just recommend the use of microbiological sample, chest imaging, and full blood count, which might be a better marker for bacterial co-infection than CRP itself. What we are unsure about, but we are using that in our hospital very frequently, it's a PCT, procalcitonin testing, which has a better specificity for bacterial infection than CRP itself. But we are still waiting for a good data, so we can't do just a recommendation, but at our hospital we are using that. And here's the list of recommended antibiotics for outpatients. So if the patient presents as an outpatient with COVID-19, they just recommend coamoxiclav, amoxicillin clavulanic acid, or doxycycline, and just try to limit the use of levofloxacin. So it's recommended only if there are not options. Maybe could I just ask you just mute yourself, please, because I'm not sure, but I think it's interrupting the lecture.
Yeah, it's the iPhone there, Danny. It shows it's on.
Thanks a lot. Thanks a lot.
Could you please someone mute it? Thank you.
Great. I think it's much better because we are doing also the recording, and that's why it would just interrupt the others. So that's for the other part of the table is for inpatients. So if there's an inpatient with suspected bacterial infection, then the first choice is coamoxiclav. And let's move on. To other part for severe bacterial infection, if there is a risk of hospital-acquired infection, because in the majority of patients the bacterial infection occurs during hospital stay, and under this situation, if it's if it's a severe pneumonia, if it's a severe patient who is just going to ICU or HDU, then there should be also the coverage for Pseudomonas aeruginosa, which is a relatively frequent cause of bacterial superinfection in COVID-19 patients. And then we should, according to antibiogram, prefer either piptazo or if it's really necessary, then meropenem. It depends on the antibiogram. And I'm not sure about MRSA occurrence in your country. So according to it, there should be also a coverage of MRSA strains, but it depends on your local situation. It's not a general advice. So that was all from my part. And I think
maybe if I may interrupt,
Anichko, what did you say?
Yeah, sorry. Oh, I mute myself. Sorry.
Yeah.
Yes. I noticed there are some questions already, and we already heard 3 presentations. So maybe I would have a short pause so they can ask you the question, and then we can continue with the presentation if you're okay with that.
No problem. Definitely, we could just do the questions and answer part, and then we could share with Petra the floor on vaccination, if it's okay.
Okay.
All right. So thank you for that, and let's move on to the questions.
¿Qué tal? Buenos días. Sí, efectivamente hemos pasado a una rueda de preguntas, una ronda de preguntas y respuestas. En caso tuvieran alguna pregunta, por favor la pueden hacer por el chat, o en todo caso pueden escribir por el chat que desean realizar una pregunta y nosotros le damos la palabra. Gracias.
Okay, maybe from our part also, the doctors please switch the interpretation to English if the question will be held in Spanish or English. I'm not sure yet, so you can switch on the interpretation to English.
Okay, I did switch. Was it a question, Anna, or not yet?
Not yet. That was just the information about how to ask the question. It can be done via chat or directly. So that's why I told you to switch it.
I could understand from the chat that there's a question about colchicine use. I can pass the floor to Slava, but we did not use it. We don't have any data for that, and I would not recommend it using it at our department. Slavo, do you have any more information about colchicine?
Well, as far as I know, there have been only some small trials with colchicine, and once again, most guidelines, including WHO guidelines, IDSA guidelines, and Australian guidelines, do not recommend use of this medication outside of randomized controlled trials with appropriate ethical improvement.
Mm-hmm. if I could understand, the second question is about if we have any experience with the use of alternative medicine. To be honest, I think that it's not a case in the Czech Republic. I think that the alternative medicine approaches are used much more in patients with chronic fatigue syndrome and in those long-term problems. And I don't know, I don't have any information. I haven't seen a patient who just tried first the alternative medicine and then go to the hospital. Well, we try to persuade the patients that there's no benefit of that and there's a high risk of potential complications in this infection. So we don't have any experience ourselves with homeopathy and so on. And to be honest, I would not recommend it. So that's my point. I don't know if Petra or Slava have any other comment. Okay. Do we have any other questions? Maybe could I just ask you, could you be so kind and write to us in a chat whether the topics which we were covering with Slava were useful for you? If there was anything new for you, or if that was really something what you know, what you already do, or if there was anything surprising for you, for example, and if it was of use for you. I would be very grateful for that. So if you could give us some feedback, that would be very useful, and it would be also interesting for us to hear that from you. Aničko, what about moving on to vaccination part if there are no questions?
Yes, we can continue because I have seen some questions already there, and they wanted to also make pass for the questions, but since there are no questions, we can move on.
Petře, ujmuj se toho.
Doctor, si me permite, doctor Trojan, veo aquí que la doctora Gavina Quispe Velázquez comenta, ¿no?, que aquí en nuestro país se dio la ivermectina como preventivo, pero no como... Perdón, aquí en nuestro país no se dio la ivermectina como preventivo, pero sí como tratamiento de COVID-19, ¿no? Es un comentario que realiza la doctora. No sé si usted tuviera, digamos, algún comentario o sugerencia al respecto. Gracias.
Thank you. If I understood well, there was a comment that ivermectin was used in your country. To be honest, I first understood that ivermectin is a little bit problematic on Harvard Medical School course in Boston last week. And they just commented that that's really medicine which is overused in COVID-19 patient treatment in South America. That's why I asked Dr. Grebenyuk to include ivermectin in his presentation. And to be honest, according to me and according to all data, what was presented, I think it's a very similar story as hydroxychloroquine. And we don't have enough data which are really of good quality to recommend the use of ivermectin. So for example, in our hospital, I just when I was asked whether to use ivermectin, I said definitely no at this moment. But I don't know if Slava would like to comment it.
Yeah, I think that the most solid data that we have on ivermectin is from this trial that has actually analyzed pharmacokinetic data from several patients treated with ivermectin for parasitic diseases or also healthy volunteers, and they have found that the concentrations that are needed to inhibit the virus in vitro are unattainable in living humans. So there is not even a theoretical possibility that ivermectin can work. That's my opinion.
I think that it resembles me the story of hydroxychloroquine. And when we just understood from a very good quality trials that hydroxychloroquine is not working and could even increase the risk of death, then we were blamed for that from the newspapers, from the media, and we tried to do our best with hydroxychloroquine, but then we understood that it was totally bad attitude. So actually, ivermectin is not included in any guidelines in the developed countries at this moment, and we are not including that in our guidelines as well.
Gracias, doctores. Thank you, doctors. Here we have another question from Dr. Américo Egusquiza. Maybe in Spanish, because I don't know how to say these medicines in English. He usado acitromicina, hidroxicloroquina con ivermectina en partes más del 50% en fases hasta moderado y se han curado con control TEM.
Thank you very much for this comment. It's very hard for us to tell anything about it. The reason is that I believe, and then I understand that the patients get better, but we are looking for, and we don't have enough data to believe that it was just due to the medication and not to other thing. So according to me, what we have as the only medication for COVID-19 is oxygen, and then potentially corticosteroids. And the WHO says the same. And well, we can't say that based on just experience of few clinicians that this medication works. We need a very good and precise data, and we did not have them with hydroxychloroquine. We use it. We used hydroxychloroquine and even azithromycin, and then from the studies we understood that it increases mortality due to ventricular arrhythmias and due to sudden cardiac deaths. So actually it was a huge problem in our country afterwards. Then it became a huge problem, and that's what we are just doing, and we are not including ivermectin because we don't have sufficient data. And if colleagues from Slovakia or if colleagues from other nations are doing that, it's their issue. I understand it. I fully understand that if you have at least some good day, at least something, if you just would like to add at least something or to give at least something to a patient, you try to do it. But you have much more better data for the use of corticosteroids. They are working much better and doing much better than ivermectin. And potentially, I don't know yet, we don't have precise data. Maybe it's the monoclonal antibodies, we will see. And there are some data for plasma. I don't know if plasma is used in your country. It's quite hard to get it, and it's a little bit complicated in terms of logistics. But at this moment, we are definitely not including ivermectin, and we don't have enough data to include it, and WHO, as the authority, says the same.
Gracias, doctor. Creo que podemos continuar con la presentación.
Yeah, I'm seeing just a raised hand, but I'm not sure whether it's a question or not.
Sí, de acuerdo. Tiene la palabra QCOM-BTD.
Okay, maybe it was not a question. So if it's okay with you, we will proceed to Petr Smejkal's presentation, and we could share our experience with the vaccination. So thank you for that, and I understand your questions, and we try to give you the best possible answers. Petr, it's yours.
Okay, thank you. I'll be a little short, but would like to give you some updates of what's going on in the country as far as the vaccination progression. Do you see the screen, or do I need a help again? Because I tried. You do see the screen?
Yes.
Okay, well, I learned something. So second attempt much better. So we are part of the European Union, which might to some people seem as a handicap, but to most of us as actually a benefit. The handicap is that the European Union was buying the vaccines as a whole and not country by country, and that's why we are now experiencing some shortage of the Pfizer-BioNTech vaccine in the country. But within a couple of weeks, basically within a month, 3 weeks to a month, we should be back to where the planned number of doses was supposed to be. The strategy how to vaccinate roughly 75% of the population, which seems to be the estimate of the herd immunity, is a little different from, for example, from England. In England or in the UK, they went by age as the major risk factor, age by 10 years down. We did a little different approach, like Germany, like Austria, I think some countries. Age was only one part of the risky group, risky points. And then there was profession, which mostly concerns healthcare workers. And then there were risk factors included. The risk factors we looked at were, besides age, as I mentioned, were number one, obesity, number two, diabetes, number three, immunosuppression in terms of transplant patients or patients who have diseases that affect their immunity, lung disease, any kind of bad lung disease from patients with reduced ejection fraction are riskier patients for COVID. And then I think I mentioned all of those groups, and then cancer patients as a group. The debate was quite sometimes big. Groups are compared to the other ones. What we know, for example, from our country or from the hospital where I work in, which we have transplant patients, that their mortality is 8 times higher than a patient with the risk factor of transplant patients, which is extremely high risk. And but that's not a worldwide data. That's just a small data from our country. I looked at up to date the data from the world, as the number is not as 8 times higher. It's probably 4 times, and depends whether it's inpatient or out, whether it's at hospital mortality or outpatient mortality. But they're certainly the most risky ones. And then heart failures are usually twice as risky as a patient without risk factors. If I take it as an independent risk factors, regardless of age, and we all know that people, with age, of course, have multiple risk factors, and it's very hard to differentiate. Diabetes was uncontrolled diabetes, for example, was probably 4 times riskier. Controlled one, 2 times riskier than a person without these risk factors. So there's a lot of debate about what is really a risky patient, and whether we shouldn't go like the British by just age, and would be fair and nobody would complain. But we've developed this rather complicated system of risk groups, and everybody basically gets a certain number of points by the risk group he's in. So he gets certain points by his age, he gets certain points by the risk factor, and if he works if he's not a healthcare worker, they get a lot of points. By definitions, they should be all vaccinated by now. They are about 50% vaccinated, but they should have been vaccinated, I should say. So besides that profession, without a healthcare worker, or a social or a worker who works in a social home who takes care of senior people, they are also with the healthcare workers. And everybody else, as far as profession, we didn't really pick up anybody who would be that risky. There was a lot of debate in the country about some essential people, so to speak, police people or high-ranking officials, head of the ministries, etc., whether they should be by profession, vaccinated earlier than other ones. But there are only a few, and of course, some of them got vaccinated, and there was a lot of talk about it. But basically, the professions as a group are only healthcare workers and people working in social senior homes. So this was chosen, and then the system of kind of a country registration was developed, that everybody registers one system, which was developed by the army, one computer system, and gets a slot based on his points of how many he accumulates as a risk factor, and where he lives, and what's the closest vaccination center. And this was kind of in progress. And then what happened? Pfizer didn't send many vaccines, so we are kind of at the limbo state right now. We don't know what's going to happen, but likely these plans are going to come back at the end of February, and we'll continue vaccinating. Like I said, we vaccinated about 3% of the population, which is very little. We think that probably almost 20% of the population was already infected or had some antibody or had some immunity response. So if you put it all together, maybe 30% had some contact with COVID. This is still far from the herd immunity we need to achieve. So we still have the virus spreading, and it's the mutations that are now driving the spread. So that's that. As far as what vaccines were chosen, and again, like I said, the purchase was done by European Union and then distributed to each member states. So we now have Pfizer BioNTech as the major vaccine, and we have Moderna as the second one. Only 20,000 doses. Basically, we sent them to the region in the east of the country which was affected the most, and right now we received AstraZeneca. As you know, AstraZeneca doesn't have much data on in elderly people, so there might be a problem with vaccinating elderly. Not that it would be inefficient, but there's just some data lacking. And what's the downside certainly of AstraZeneca is that if we do have mutations that will affect the people, Pfizer
Můžeš to zopakovat, prosím, vyplavilo ti připojení.
For sure. Johnson & Johnson is planned also to get to Europe at some point of time, but we don't know when. And it's basically a similar the Gamaleya Institute vaccine, the Russian vaccine, is a political issue in our country because for some reason Sputnik, and you probably know, just published in Lancet very good data on the vaccine efficacy and safety, but they didn't ask the European Medical Authority, the European EMA, the European Medical Agency, which is like an American FDA. It's a bureau for approving the vaccines, was not asked by Sputnik for registration and approval. So we don't know why this is happening. We don't know whether this is a political issue, they're hiding some data. So legally, basically, we have issues with using Sputnik in this country because it doesn't have an EMA approval. It's like in the US, if you don't have an FDA approval, obviously you cannot, it's very hard to, use it. There are one country in Europe, Hungary, that's for political reasons kind of doing its own policy. They just got Sputnik, 200,000 doses, and they will start vaccinating with Sputnik, despite the fact that it doesn't have an EMA approval. The Hungarians are saying, we don't care, basically, it's an emergency. It's a situation where we don't have Pfizer, we don't have anybody else, so we'll use Sputnik. But I think in the Czech Republic, this might be pretty difficult. I don't think we'll end up using Sputnik, but we'll see. Certainly, we do regard it as good vaccine. I have no concerns, but I just don't, and many others don't understand why Sputnik just didn't go the proper way in asking for approval in the European Union. So those are the vaccines we're supposed to have. Of course, there's going to be again the whole world wants vaccines. I'm sure I would like to know what in Peru you are going to use or you using. So there's certainly going to be some problems with production and distribution and mutations possibly, but we hope that by spring in our country, which is like May, June, I think the majority of risk groups are going to be vaccinated. Problem with Pfizer is that you have to store it at -70 degrees. So the primary medical doctors, the GPs, do not have the refrigerators to store it. So they basically have to wait for AstraZeneca to start vaccinations to store it. So that's why the actual vaccination in our country is happening in the so-called vaccination centers, which are mostly hospitals at this point. And you can imagine that hospitals who lack workers, and currently it's better because, like I said, most of the healthcare workers are vaccinating, but in the times when they were in quarantine and isolation, they certainly didn't have time also to be employed as working in vaccination centers. So we use nurses currently in our hospital to vaccinate, and we have a doctor supervising the vaccinations. Because by Czech law, they must be a doctor present, but the nurses can do the job. We do not use pharmacies, unfortunately, like in the US. I don't know what's the legal system in South America, whether pharmacies can vaccinate people, but in our healthcare system, that is not possible. We try to vaccinate patients in hospitals who were just before release. So we do as much as we can to vaccinate as quickly as possible, but there's these bottlenecks, limiting factors, like the lack of vaccines at this point, only places where there is a doctor, certain regulations, and lack of the vaccinating sites. There are plans, there's going to be some big arenas and stadiums where a high-speed vaccination will take place as well. And of course, there's going to be general practitioners vaccinating with the vaccines they can, but there's going to be only a minority. So the to summarize, this is 3 major points of vaccinations will be big centers. There's not going to be many, I don't think. I don't think so, unfortunately. Then hospitals as vaccination centers with mobile units. For example, some of the senior homes are vaccinated by mobile units that go from the hospital, and then general practitioners. So, we hope that the summer certainly will be, like I said, we'll have the risk group vaccinated, and that by vaccinating the risk groups, the burden on the ICUs and on the hospitals will diminish, because that's the point of concern at this point, as we really have flooding over certain hospitals, and that's why we need to keep the lockdown going on. So we hope that the hospitals will kind of feel the effect of vaccination on the risk groups. What happened in Great Britain, for example, that the ICUs didn't empty as much, but they did suddenly had an increase of patients of age 60, 70 instead of the elderly ones, because they basically a lot of them didn't even make it to the ICU. So until I think we vaccinate the risk groups and people age 60 above, we will still, feel the effect of the COVID pandemic. So, what are the problems of of the hospital vaccination in our country is the bureaucracy, of course, because every vaccine needs to be put in the computer, registered. You know, it's a centralized system of booking and reservation, which in my view is a little excessive, because every hospital has its own reservation system and has its own system of patients. But that's, you know, we live in a country with a lot of centralized government system. So this is, I think, a little minus factor, but the army did it and did it quite well. So maybe it's not going to be that bad. The necessity doctors' input you see in Israel and other countries where basically there is no need to have a physician. There is a need to have to be somebody who can administer, you know, EpiPen, hydrocortisone, and treatment for allergic reactions. And that necessarily doesn't have to be a doctor. In our country, there must be a doctor, and that's probably, you know, the drawbacks or the minuses I can see for now. As far as major, you know, side effects of the vaccines, we didn't see many. We see exactly the number of allergic reactions, which was, I think, 1 per million, I don't know what the exact number is, as the Pfizer producers said. We see a lot of local reactions as far as pain, fever, kind of a COVID-like symptoms. We see way more reactions after the second dose. We have a lot of people who had to take a sick day after the second dose of the vaccine among the healthcare workers. We don't see many of these reactions in elderly people, which is, I think, to the fact that the elderly people cannot mount an excessive immune reaction and do better actually with the vaccines, that some of the people of my age would be like 40, 60, 40, 50 that, like I said, had to stay home. But otherwise, nobody died. We didn't, we didn't, as far as allergic reactions, there were some. And the only contraindication to the vaccination was actually a severe allergic reaction to a vaccine in the past, or some part of the formula of the Pfizer vaccine. Otherwise, we didn't discourage anybody. There were a lot of rumors about certain diseases like multiple sclerosis or certain immune diseases for them not to be vaccinated. But then I think a lot of the immunologists in the country were criticizing widespread vaccinations, but after that there was a deal between the Infectious Disease Society, Immunology Society, Vaccination Society, that basically the only contraindication is a severe allergic reaction to previous vaccines. Because of vaccines obviously were not tested on pregnant women, we generally do let them decide on their own. There are studies that in third trimester COVID, women have more severe course than non-pregnant women. So a lot of the pregnant women are choosing to be vaccinated actually. And most of them do that in the second trimester to avoid the first trimester, which is, of course, always the most questionable. But I think that a lot of them do want to be vaccinated. As far as, and this is Prague at this moment, which is covered by snow, which we haven't had in 10 years, so I put this article there. As far as the whole kind of effort to vaccinate, Czechs are very skeptical people. We have a problem with very conservative healthcare worker community. We never had many healthcare workers who would be willing to get a flu shot every year. As far as COVID vaccine, this is better because we've seen some really tough times. So most of healthcare workers are getting COVID vaccine. And as far as the society is concerned, I have some new data from the statistical institute that says that currently last year it was 40% people who were willing to get a vaccine, and suddenly it's 52%. And only 20% are categorically against the vaccination. And of course, the younger people, the less interest in the vaccines there are. So I think this will go up with the times that people, saying, look, there's no side effects. So I hope we'll get to at least 70%. So currently 50% are willing. So, and that's from me all at this point, and you can ask questions later. Thank you. I'm handing over to whoever is next.
There may be some questions about the vaccination. And the first one is how difficult it was to start with the vaccination or to realize it at the first.
So actually, I could answer for our hospital. It was on the 27th of December, and it was during the Christmas holidays, so it was a little bit tough. My colleagues and the head of our department had to just order that there will be some amount of doctors who would go to the hospital, but we started with the vaccination of healthcare workers, so of the workers of our hospital. So it was quite easy to get a lot of volunteers to be vaccinated, because those were just the healthcare workers who were really willing to be vaccinated. So there was a huge amount of them in the first days, but it was quite simple. But we had to set up some vaccination center, as Peter has mentioned, and nowadays the capacity is much higher. So we had to, because we work at the infectious disease department, we had to ask the colleagues from other departments all around the hospital to help us, and we are running a vaccination center 7 days a week and 12 hours a day. Nowadays we are just moving to vaccination of seniors or of the elderly, and we have finished, or we are finishing, the second dose of vaccination in healthcare workers.
Okay, the other question is that only like 3% of the population was vaccinated. How was the prioritization of the people? How you decide who's gonna have the first, who's gonna be the first to be vaccinated?
I think that Petra mentioned that in his presentation. So first of all, those were healthcare workers, so the doctors and the nurses in hospitals, and then the elderly, and then there are priority groups which are really waiting, because we are having the lack of the vaccines at the moment. So we will see when the other high-risk groups will be included. If there were any vaccines in the center, if there were available any vaccines, we sometimes did a vaccination to extremely high-risk groups, like patients after transplant, organ transplant, or really high-risk immunodeficient patients. But it was not in the plan. It was just if there were any vaccines left, because at this moment the priority is the elderly over 80. But I think that Petra could add some more information from his point.
Yeah, we got a special, the hospital I work in got a special permission to vaccinate 70 plus transplant patients. So people who have transplant recipients or are on the waiting list, and are 70 years and older, got a special permission from the Prague vaccination boss to vaccinate it. But basically, there was an exception. We still, like Milan said, unfortunately, we are 2 months, almost, we're going to be 2 months into the start of the vaccination, end of December, and we just did healthcare workers and seniors in social homes, and senior people above 80 years old, where the age is a risky group. Otherwise, we didn't even get to the risk groups defined by disease and defined by risk factors. So, which is sad, because people are
I think that the message was quite clear from Petra, and we would be very grateful if we could just proceed.
Occupier of us and brought us communism, and suddenly they have vaccine. They're trying to sell and a lot of people say, I would like to get the ration. A lot of people, so it's becoming a political issue. Unfortunately, a lot of the epidemic was politics.
So I could support what Peter is saying.
We will be back with Pfizer deliveries where we're supposed to be, and we'll start with the risk groups. And the only bottleneck will be the system and not the amount of vaccines we're getting. But you know, this is not for the next 3 weeks. So we are kind of, yes, like Milan said, we just, you know, we are at the very beginning. And people suddenly, when they heard there's a shortage, it's interesting that, you know, there were 39% interested last year, and suddenly that's 50%. People reacted quite well to the news that there is shortage of vaccines, and suddenly, you know, people are getting interested because there is a shortage. So, you know, so, but certainly we do have people, we have a lot of people infected after the first dose. We should also mention, you know, there's a lot of big surprise that people got infected after the first dose. And if you look at, there is a good article in New England Journal of Medicine that basically the immunity starts 14 days after the first dose. So it was to no surprise that we still had COVID positives, sick people after the first dose, but we had very few after 14 days after the first dose. And we still have some even after the second dose, but with a very mild course of the disease. So the vaccine does protect, it works against the variation of concern, the British mutation. And if it doesn't work against other mutations, it will be quickly fixed by Pfizer, so they say. But you know, we need it. So I don't know what the situation is in Peru as far as vaccinations. I think we'll be all eager to know what vaccines use.
Thank you, Dr. Michael. Thank you, Anna. We have to finish our seminar. But first of all, I want to thank you. First of all, I want to thank Anna Paklova, coordinator of the Medical Humanitarian Program, and Dr. Esmekel, Dr. Trojanek, and Dr. Grembenjuk for their presentations. I will also want to answer your question. I will do it in Spanish regarding the vaccinations campaign. Acabamos de recibir 300,000 dosis de Sinopharm que llegaron, si no me equivoco, el domingo por la noche. El gobierno ha establecido una campaña nacional de vacunación. Todas las vacunas van a ser administradas en centros de vacunación autorizados por el Ministerio de Salud.
Well, I'm sorry to interrupt you, but the translation to English is not working right now. So I don't think that the doctors understand you right now. So otherwise you would have to present your in English, because probably the translator or...
Let me ask the colleagues of the of ENSAP about the translation. Hector?
No. Yes.
Hello, Hector.
Hello.
Yes, no, I'm asking my colleagues of ENSAP about regarding the translation. Hector, Haida. Oh, okay. We don't have the translation system anymore. So first of all, I want to introduce myself. I'm not a doctor. My name is Julissa Machiavello. I'm the Director of International Cooperation of the Ministry of Foreign Affairs. So I will try to be accurate regarding what I'm going to say. But we have started the vaccination program. We have divided in 3 phases or 3 etages. First of all, we have all the professionals and doctors, no, that are like now in the hospitals, and Fuerzas Armadas, no, police, national police. Then we are going to have a vaccination special because with the elections, the national elections are coming now on April. So we're going to vaccinate all the people that are going to work in these elections. On the second phase, we have the elderly people, besides 60 years old, and people that has other disease, that can have create similar problems. Then in the same phase, that is the second phase, we have the native and indigenous people, because the government has divided the country in 3 different areas regarding how the impact of COVID-19 has been established in different localities or regions. So we have the stream, the regions, so that is very, very, very hard what is happening with the hospitals and the mortality that you also were explaining to us in the presentations. Afterwards, I'm going to say all in Spanish for my colleagues in Peru, but it was very impressed for us in the Ministry of Foreign Affairs when we were listening both of the 3 of your presentations, that we have similar things that we are confronting regarding the medicines, that we don't have like data of all the medicines, especially of the ivermectin, that we are like that here we are implementing the treatment with ivermectin, but we don't have like data, accurate data, or the problems that we are going to have also regarding the vaccination, because we only have now 300,000 vaccines from Sinopharm. Yesterday, the government has signed an agreement with Pfizer for 20 million of vaccines, and we are going to receive also vaccines from AstraZeneca, but we don't know when they are going to arrive. We are waiting for them. But if we calculate the number of vaccines that we need to finish these 3 phases, because the 3rd phase is for people between 18 and 59 years old, we need over beyond 49 million of vaccines. So it's going to be a hard way to go. I think we have been like implementing some regulations in order to deal with the registration, because that's another problem. And I remember, and in the presentation, the last one that Dr. Esmegal put there was the control, how the government is going to control who's going to receive the vaccines. So there's a lot of question marks, interrogations in this phase. And then to finalize and to conclude, I just want to thank the Ambassador Liliana de Olarte and her team, because of her and because of our embassy in Czech Republic, it is possible to have you here, virtually speaking, but have you here and to share your knowledge with all the professionals that are here today, that are over 90 people. There were 98 in a moment, I was like checking that. And then I want to emphasize that this is the first seminar, video conference, regarding these matters that we are having this year. With Czech Republic is in its initial sizes, starting this program of seminar regarding COVID-19. We had last year 3. We started the last semester with 3 countries. The next weeks we are going to have another with Austria and Singapore. So thank you very much. I hope you are well, and then we wish you all the best. And thank you. Gracias a todos por haber participado en este seminario. Es uno de los muchos que hemos programado junto con la doctora Eliana Inicio de la Escuela Nacional de Salud. Es la primera capacitación o seminario virtual sobre el impacto del COVID, los tratamientos y las nuevas etapas que se vienen con la vacuna. Y República Checa es el primer país con el que iniciamos este importante cronograma de capacitaciones virtuales. Estaba explicando las distintas etapas que tenemos nosotros programados, establecidos por el gobierno peruano, de las 3 fases de cómo han separado a las poblaciones, qué contratos hemos hecho y qué vacunas ya hemos recibido, y el contrato de Pfizer que recién ha salido hace 1 o 2 días por 20 millones de vacunas. Les he explicado que coincidimos en los desafíos que nos presenta este virus, tanto operativos, ¿no? Como también las medidas que tenemos que implementar como países, tanto gobiernos como la parte de sociedad civil, para hacerle frente a la COVID-19. Les agradecemos mucho de parte de la Cancillería, de la Dirección de Cooperación Internacional, haber podido participar el día de hoy, y seguimos en contacto. Muchísimas gracias.
Thank you very much, and we really do appreciate that you attended those 2 hours with us. I fully understand all your questions, and we were very grateful that we could share our experience, because we know that we did a few things not in a good manner, so we try to give the experience to the others to avoid the same mistakes. So thank you very much for that, and take care in Peru.
Thank you so much. Also have a great morning in Peru. Have a great day, and hopefully we'll see each other soon, maybe during some other conference.
Yes, thank you. I hope so.
Goodbye.
Bye.
Gracias, gracias.
Thank you. Bye-bye.
Bye.